Today we are going to talk about the upper GI bleed or upper gastrointestinal bleed. Upper GI bleed is another very important topic when it comes to the doctors working in the emergency department and the intensive care unit. Because if we can manage the upper GI bleed in a timely fashion and properly, then we can help to save the life of the patient. So this is always very important to have some basic idea about the upper gastrointestinal bleed. Let's talk about it. Let's talk about upper GI bleed or upper gastrointestinal bleed. Upper gastrointestinal bleed. In abbreviation, we write it per GI UGIB. So any bleeding which is happening from the gastrointestinal tract above the level of ligament of triads. This is a very important anatomical landmark when we are going to define the upper GI bleed, ligament of triads. So any bleeding from the gastrointestinal tract, above the level of the ligament of triads is known as upper GI bleed. Any bleeding from a part of gastrointestinal system above the level of ligament of triads. Ligament of triads is known as upper GI bleed. This is a very important definition actually. We so oftenly receive these patients in the emergency department and ICUs. They are complaining of bleeding from the GIT tract. How we can know that they are complaining of the GIT tract bleeding? There would be certain sign and symptom which we are going to talk about later on. But as a first part of giving definition, any bleeding from a part of the GI or the gastrointestinal system which is happening from above the level of the ligament of triads is known as upper GI bleed. So, if we talk about these things of the upper GI bleed, where lies the ligament of the triads? If we make a short diagram of the GIT tract here, from where the bleeding is happening, say this is esophagus. This is esophagus. This is the part where the lower esophageal sphincter is located, and here starts the stomach. So if we make this stomach, this is stomach. This is stomach. And then starts the duodenum. First part, second part, and the third part. So this is esophagus. This is esophagus, which we call the food pipe. Then this is lower esophageal sphincter or the junction, or the gastroesophageal junction. The first part of the stomach is known as gastric antrum. Gastric antrum. This part is known as the fundus of the stomach. Fundus of stomach are very famously known as gastric fundus. This is the body of the stomach. Body of stomach. And here comes the pyloric part of the stomach, pyloric antrum, pyloric antrum, and this is the pyloric sphincter here, and this is the first part, second part, and third part of the duodenum. First part, second part, and third part of the duodenum. Now, ligament of triads is actually attached here as a suspensory ligament. Ligament of triads is attached to the last part of the duodenum, or the near to the second and third part of the duodenum is the ligament of triads. Now, when we talk about this very important part, looking at the anatomy of the upper part of the gastroesophageal system, this is the esophagus, this is the start of the stomach. Here you see the lower esophageal sphincter, this part, and we can also call the lower esophageal junction or the gastroesophageal junction. Then these are the parts of the stomach. This curve is known as the lesser curvature. It's a lesser curvature of the stomach. Lesser curvature. So if stomach has got a lesser curvature, it would probably will have a greater curvature at well, which is this part. This is the greater curvature as opposed to the lesser curvature. Again, these are very important points anatomically speaking. Now, this is the gastric antrum. This one is the fundus. It is sort of hollow portion this upward. I haven't made it that way, but it goes like this. Then here comes the larger portion of the body of the stomach, and this is the pyloric antrum, and there is a part of the then we have this first part of the duodenum, second part of the duodenum, and third part of the duodenum. Now, this is also known as the cardiac antrum, because this is the cardia part, fundus part, body part, and pyloric part. And this is where the ligament of triads is attached as a suspensory ligament towards the very last part of the duodenum. And any bleeding happening in an area of the gastrointestinal tract above the level of the ligament of triads is known as upper GI bleed. Now, major portions which we should encounter in like coming debate about the upper GI bleed, these would be duodenum, because duodenal ulcer so many times happens here. Then gastrum or the stomach, gastric ulcer, especially around the area of the lesser curvature. And then the esophagus, because varices can happen over there and they may be a source of the bleeding, which we call the upper GI bleed. So this is very important to remember this anatomical composition of the area from where the bleed starts. So let's now talk a little bit more about the main causes of the upper GI bleed. Now, any bleed happening above the ligament of the triads is actually known as the upper GI bleed. Now let's be a little bit unorthodox, and let's say because the debate should be like started from how the patient present, then we'll come back to the actually reasons or etiology of the upper GI bleed. How these patients present in the emergency department or in the ICUs, presentations. You can also call the symptoms of the patients. Let's be a little bit more conceptual rather than going by the book, because first we need to understand how these patients come to you, and then we'll talk a little bit about the etiology. These patients are coming either with the complaint of hematemesis, emesis of the heme, or emesis mean vomiting, heme mean blood, so vomiting of blood. vomiting of blood or blood in the vomitus. Blood in the vomitus. In majority of the cases, this is a fresh blood because our mouth is located nearer to the upper GIT tract as compared to our anus. Because our anus is located far away from it, so the blood which is being thrown out through this orifice of our GIT tract will be fresher as compared to the one which is coming from the downside of the tract. So hematemesis or vomiting of the blood or blood in the vomitus is one cardinal feature of the patients of the upper GIT tract bleeding or upper GI bleeding. Now, this is one very important point to make a difference between the hematemesis and hemoptysis. This is so many times can happen that we can confuse the two things not only by definition but also by clinically. Hemoptysis. What is hemoptysis? Hemoptysis means coughing of the blood. Now the blood, if it is coming with the cough, now remember one thing, that cough can be a strong cough, can be a reason of hematemesis, like in cases of the Mallory-Weiss syndrome or esophageal rupture. Esophageal varices they got ruptured, but there are certain situations where the patient comes with a complaint of cough and that cough throws up sputum having the blood, that will be known as hemoptysis, and its source in majority of the cases is actually from the lungs rather than from the GIT tract. So this is very important, and I have personally seen some cases where the patient was having the source of the blood from the lungs and it was a brisk blood because there is arterial rupture in those cases, and they are coughing out so much blood that the doctors mistakenly took it for as hematemesis. Patient underwent the endoscopy and later on it turned out to be hemoptysis, and patient had bronchoscopy and there was a source of the arterial blood from the bronchial tree, and the family got really offended on this, that the doctor made a huge mistake by confusing the two terms. So always be open-minded, always try to make a difference between the two, whether this is the hematemesis or the hemoptysis, because this will help in the longer term. So hematemesis is one cardinal feature where with which the patient comes through the ICUs and the emergency department. So after hematemesis, there is melena. Melena. So melena is passage of the black Tory stool. Black Tory stool. The color of the coal tar. The color of the tar, jet black. It will be very, very black, and patient will be passing stool which will be black, pure black, like when the roads are being made, especially in the past, they used to have coal tar that was actually sources from the coal, and it is really black. If those stools are passed, this is known as melena, and the source is most probably, in majority of the cases, sources from the upper GIT tract. Now, as I already mentioned, the both melena and hematemesis, they are coming from the same source. But because anus is located further away from the source of the bleeding as compared to the oral cavity or the orifice, so this blood will be fresh in the majority of the cases and it can be clotted. But in majority of the cases, melena will be black Tory stool, and because the blood, when it is going all the way through the GIT tract, is being processed and the heme has got its change colored to the black entity. So melena is passing of the black Tory stool, and the majority of the cases the source will be upper GIT blood. Any bleed from above the ligament of the triads will be known as upper GIT blood. Now the third thing is, it can be hematochezia. It can be hematochezia. Hematochezia means bright red stools. Bright red stool or bright red blood in stools. Bright red blood in stools. So hematochezia, though there are chances that then again you will have to be very skeptical of the hematochezia because its source can be from the lower GIT tract. But in majority of the cases, if you see a stool passing and there is a bright red blood or only the bright red blood, it can be from the upper GIT bleed. And the reason of it being bright is that it's so brisk, that it's so profusely bleeding. The source of the blood is so profusely actually giving up blood that it's coming down very fastly. If a large quantity of the blood are being just dumped into the upper part of the GIT tract, they, with the effect of the gravity, they will be continuously going downwards all the way through the GIT tract and will come out of the anus in a bright red form. So there is not enough time for the blood to be processed to be converted into melena. So hematochezia can be a complaint of these patients, but be very skeptical of it. Try to find out some down source of it, like try to find out the lower GIT tract source. Do perform per rectal examination because the patient may have hemorrhoids, patient may have anal fissure, patient may have any other source of it from the area over there. But do not forget that in the pathogenesis of the portal hypertension, there are some venous dilatation in the rectal area, and that can be a source of it, and we'll have to make a difference between the two, because bleeding from the rectal area as a source of the venous dilatation because of the portal hypertension is not hemorrhoids. Hemorrhoids will be a different thing. In majority of the cases, it can have a source in the upper GIT bleed. So hematemesis, melena, and hematochezia, these are the cardinal symptoms of the upper GIT tract bleeding patient. Now, another thing, these patients may not be bleeding heavily. They may be having this problem for a longer period of time, and they may be passing microscopic blood, which we call the occult blood in the stool. In those cases, these patients present to the emergency department with the complaint of anemia. So the symptoms of the anemia can be generalized weakness, fatigability, then there can be early satiety. They cannot eat much, though it's a very subtle complaint, but it does point towards something happening in the upper part of the GIT tract. People may be having gastritis or something like that, and they are not wishing to eat much, and so they stop eating at an earlier stage. So if they are having these nagging symptoms for a long time, nagging bleeding for a long time, they may develop generalized weakness, fatigability, early satiety. There may be paleness, the yellowness of the skin as a result of the anemia, yellow skin. So these are the main complaints or the clinical symptoms with which the patient is coming to the emergency department and intensive care unit. Now, I wanted to talk about the symptoms before the etiology, because knowing how these patients are coming to the hospital is the first part a doctor is coming across with the patient. So the etiology comes on later on. So better we first talk about the definition of the problem, then go to the symptom with which the patient is encountering the doctor or the hospital staff. And the third comes the causes of the upper GIT bleed. So let's talk a little bit about the causes or the etiology. If we talk about the etiology of the upper GIT bleed, we shouldn't forget the anatomy of the upper GI bleed. So if we just see make a very short diagram of that anatomy. Okay, so etiology of the upper GIT bleed does include the following situations. Let's be a little bit systematic in our approach towards the causes of the upper GIT bleed from the anatomy point of view. This is esophagus. What can be the problem here? There can be a problem of esophageal varices, esophageal varices, which happen in the patient of portal hypertension, and the majority are the 90% of these cases of the portal hypertension are because of the chronic liver disease or the liver cirrhosis. Though there can be other problems as well. For example, schistosomiasis, Budd-Chiari syndrome, other thrombosis can cause actually thrombosis of the veins can cause this portal hypertension, which becomes a reason of the esophageal varices. Why the people develop actually esophageal varices? Because if we see, say this is spleen, and from here coming splenic vein, and from here comes the superior mesenteric vein. Both they join to make the portal vein. This is splenic vein. This is splenic vein, and this is superior mesenteric vein. Both they join to make the portal vein. It actually opens in the liver. This is liver. Then from the liver comes the hepatic vein, and this hepatic vein then joins inferior vena cava, IVC. So if there is a problem with here, in the 90% of the cases, this is the cirrhosis of the liver. It doesn't allow the portal vein to let the blood pass through the liver. So portal vein actually then develops some collaterals to actually let this blood go through those collateral to the systemic circulation, which we call the portosystemic shunt, because portal vein is no longer able to let the blood go through the liver because of the cirrhosis. Now, the majority of the cases, those collaterals, they are present in the esophagus, around the umbilicus, and in the rectal area. But here we are concerned with the esophageal veins, because once higher back pressure goes to these collaterals, they dilate, which we call the esophageal varices. So esophageal varices are a very important source of the upper GI bleed, and when they do bleed, they bleed really heavily. So one is when we talk about the esophagus, one cause of the upper GI bleed is esophageal varices. Secondly, from this part can be esophagitis. If there is inflammation of the esophagus, and sometimes it can bleed because of the very severe inflammation, esophagitis can be a reason of it. Thirdly, if someone is vomiting very profusely, then the lower part of the esophagus or upper part of the stomach, it ruptures, which we call the Mallory-Weiss tear. Mallory-Weiss tears or syndrome. Sometimes what happens, that because of very excessive vomiting, there are some veins or arteries, they get ruptures and they start bleeding, which we call Mallory-Weiss tear or Mallory-Weiss syndrome. Now another cause can be a very severe vomiting, can actually rupture the lower part of the esophagus or upper part of the stomach, and patient may bleed very heavily. We call it Boerhaave syndrome. Boerhaave syndrome, and this is a surgical emergency because these patients do develop left-sided pleural effusion, subcutaneous emphysema, left-sided pulmonary infarct, and these patients need immediate surgery, because in Boerhaave syndrome, these patients actually get the rupture of the lower part of the esophagus and upper part of the stomach because of very heavy vomiting. So these get antiverted, these parts get antiverted. So we call it Boerhaave syndrome. Then the last reason of the esophageal source of the upper GIT bleed can be a severe reflux esophagitis. Severe reflux esophagitis can cause some changes in the part of the esophagus, and this can become a source of arterial rupture or arterial inflammation to the extent that it can bleed. But the majority of the sources of the upper GI bleed from the esophagus are esophageal varices, Mallory-Wistar, and Boerhaave syndrome. These three are the most important reasons. These three are the most important reason and should be remembered by the students and the doctors, that these can be a source of upper GIT bleed from the esophagus. Then comes the down part, that is the stomach. So what are those causes which can be a reason of upper GIT bleed from the stomach? Now let's talk about the causes in the stomach. So when we talk about the causes in the stomach, then we shouldn't forget the role of two or three major things. One thing is the NSAID use, which is so prevalent nowadays, and people so oftenly use NSAID without knowing the its adverse effect, especially on the kidneys and the stomach. Then another thing can be the H. pylori, which acts as a major causative agent in cases of the gastric and the duodenal ulcers.